whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and chief medical officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. Today, we're talking to Dr. Rhonda Zwingerman. She's an entrepreneur and physician. She's the medical director and co-founder of Twig Fertility. She's an obstetrics gynecologist specializing in reproductive endocrinology. Dr. Zwingerman, thank you for joining me today.
Thanks for having me.
So Twig Fertility, where'd the name come from?
Oh, it's a great question. So our tagline is every nest starts with a twig. So the idea was we wanted a name that was kind of fertility adjacent, but not too on the nose. And Nest was taken by Google. So you couldn't search engine optimize that up against Google. And so we did a really extensive kind of branding exercise and had hundreds of names. And it was the only one we all immediately gravitated to. And so we went with Twig. It turns out someone owned the trademark. They weren't using it, but we still had to buy it from them. And there was a bit of legal drama at the very beginning.
How do you even hunt down the person? How do you find that out?
I think you have lawyers who do that.
Okay. You weren't banging on doors.
But I think now we have the trademark to use Twig for a whole host of things that we won't. Like utensils or, I don't know, very random things that we had to buy the trademark for. So every nest starts with a twig, though. That's the idea.
That's funny. When we were naming the company here, we wanted to name it Apple because of the association with doctors and apples. And then my business partner aptly noted that that was already a company as well. So I feel your pain on that. The naming can be tough.
It was very hard, right? And with the other thing we very purposely did not want to do is name it after me or after a doctor or after a location, because what we were really purposely trying to do was make a national fertility brand. And so we wanted it to be able to grow and be bigger than any one person or any one place. And that was very purposeful.
Very cool. Yeah, start with the end in mind.
Something like
and
that.
So
yeah.
Tell me more about Twig. It seems like you guys have grown to quite the size at this point, including multiple locations. You guys must be doing something right. What's going on?
So Twig is a full-service fertility clinic and company. We launched in early 2022 with our kind of flagship location in Midtown Toronto, and that includes our IVF lab here. And then just last spring of 2024, we opened our first satellite location in downtown Toronto, and so that has clinic space, it has diagnostic testing space, it has andrology, but there's no IVF lab. And then we're currently in construction for Vancouver, Twig Vancouver, hoping to open spring 2025. And the idea really is to elevate the fertility care experience, to provide a better fertility care experience to the people of first Toronto, Ontario, and in Canada.
Well, congrats on the interprovincial expansion. That's super exciting.
Mm-hmm.
What was it like getting started during COVID? How did that impact things?
Well, I will say I've never started a business not during COVID, so I don't have a lot of comparison. But one thing that was, I suspect, unique is that my co-founders and I business dated on the phone for quite a long time, and then by video before we ever met in person. And I think when we all quit our jobs, them on Bay Street and me at my academic center where I was previously, I think we had met in person maybe twice in a backyard, right? Somewhere. And then we had to do all of our interviews and build our team and onboard the team and train the team and try to develop that culture fully virtual because we were in construction. So we didn't have a physical space, even if we could safely gather together. And I think that it made us be really thoughtful about how we do that and how do you build culture and how do you get that sense of team. And I think that actually set us up for success in many ways. It also made us quite nimble in terms of hybrid working and adapting to the realities of how patients like to see their doctors today. What was challenging was the actual construction project and sourcing things that you couldn't go to see. And so you had to choose everything based on like a tiny thumbnail print on some picture on a computer and then hope when it showed up, it would show up like you wanted it to. So I think for actually building, it's much nicer when you can go to showrooms and vendors and touch the things that you're going to spend hundreds of thousands of dollars on. And there was that little bit where lumber was like worth, its weight in gold, which was challenging. But I think for the most part, just kind of like any entrepreneurial journey, you just kind of make it work, right? You just like do it because that's how you do it. I don't know if that makes sense, but
Figuring it out on the fly, definitely.
kind of do it. Yeah, you're like, we just got to get it done. How do we can make this work? Kind of attitude.
How did you get connected with your co-founder then during COVID virtually? How does that even come about?
Yeah, so it was a little bit before COVID. It was January or February 2020 when I got an email from a mutual friend. And she said, hey, I have these two guy friends and like they're interested in maybe doing something in the fertility space, but they like are trying to speak to as many like fertility docs as possible to figure out like, they kind of don't even know what they don't know at this point. And so I said, sure, I'll talk to them. And we actually had a coffee date in person that was planned for March 13th, 2020. Which was, of course, the day the MBA closed and everything unraveled. And so we rescheduled to a phone call 2 weeks later, and kind of the rest is history. Obviously there's a lot, but after that first phone call, things really just kind of snowballed from there.
And did I hear you say it cost a few $100,000 to set up a fertility clinic?
Oh,
Is that right?
It costs a few $1 million to set up a fertility clinic. Yeah, so the clinic itself is the clinic, but the IVF laboratory, this is a capital intensive business, which is why I have two co-founders who are from the business side of things. And what they knew how to do was raise capital. Because I obviously didn't know a lot about raising capital or valuing companies or any of that before I started this process. I do like to say I got an MBA by fire, like a real life, just by living it. And so, yeah, we did an initial friends and family round to build the first site. And then we've done a Series A with some venture money to back our expansion to downtown and to Vancouver. And the reason there's not a lot of new entrants in this space is because it's the combination of capital and regulatory is like a pretty scary combination.
This podcast was brought to you by Cherry Health, the healthcare jobs network with over 35,000 jobs across Canada and the US. Physicians, nurses, pharmacists, and all other healthcare professionals can sign up for free. Start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across North America. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with thousands of new jobs posted every week. www.cherry.health to get connected today. Yeah, no doubt. Holy smokes. Okay, now I see why it's referred to as the startup then, and a lot of the documentation there is just truly going on that like raising capital growth trajectory, and then the expansions make sense. All right, I think I'm following.
Mm-hmm.
What cost the most then out of those millions of dollars? Are there Da Vinci robots hanging from the ceilings, or where does that actually go into?
There's no Da Vinci robots. A lot of it actually is the HVAC system and the mechanical.
Really?
Yeah. So the better the air in the lab, the better the embryos grow. And so there's some really fancy air systems that go into maintaining, into cleaning and filtering and having like a high turnover of air in the lab. And the incubators are very expensive. What's called the ICSI rigs, so the fancy machines where you get to inject one sperm into each egg, are very, those obviously cost money. And then you need a lot of alarms and checks and sensors for all of your equipment, but also all of your tanks that are storing people's eggs and sperm and embryos, right? So you also need a really robust backup generator, backup alarm systems, like all of that adds up. And then you have the clinic side, and then we also have an in-house pharmacy as well. So it's all of it.
Is there a more expensive clinic in the province of Ontario right now?
I mean, there are fertility clinics that have built bigger footprints than us. We were actually really mindful to be as efficient with space as possible. So there are clinics that have a much bigger footprint that have been built since ours in Canada. I don't know what their price tag was, but I suspect if it's twice the square footage. I have no idea what a plastic surgery clinic costs, but that would be the only one I would think of that's comparable in a way. But I have no idea. So
That is wild. That is wild.
Yeah, it's complicated of a business, that's for sure.
How did you even go about getting that all set up with like the HVAC and the cooling and all the cryo things? I'm assuming they don't just teach you all this in residency, how to go and DIY it.
No, so the answer is we hired an unbelievably amazing lab director as our employee number one. And how we found her is amazing because it's totally serendipitous as well. Because she was working at a genomics company and we were trying to do a financial model. So we cold called the genomics company to ask them about their prices, and she picked up the phone. And next thing you know, she was our employee number one. And she also had not had firsthand experience designing her own lab, but we had worked in embryology labs, and we just that's why I didn't do clinical work for 14 months from when I quit my job till eventually I opened their doors to patients. Like, we talked to everyone. We took every call. We virtually went to every vendor and conference and thing we could. And just at 11 p.m. on Friday nights, we're on the Google Meets with the whiteboard, with a floor plan, and being like, oh no, we need a sink in that room. And kind of, what can we move? If, that was our life for a while. And the whole time I was like, oh, I love this so much. What if I love this more than clinic? Like, what if when I go back to seeing patients, and then I went back to seeing patients and it's also great, but I truly love both. And that surprised me so much, right? Like, I had no inkling that I would love that part of the adventure.
And then at this point, how much of your week is clinical patient facing versus ops and, behind the scenes?
My clinic volume right now is pretty close to a full patient load. And then I also do all the stuff on top. So I work more hours maybe than in an ideal world, but again, kind of startup life. Like, the other physicians on my team are amazing. Some of them are relatively newer to the team. Like, we've just grown fast in terms of physician size as well. And so until we have, I would say, a group of physicians with more mature practice, it's hard for me to step back. So I'm still basically 100% clinical plus all of the leadership and management. And that's okay. It's not going to be like that in 5 years from now, I hope. And also, hopefully in 5 years from now, I'm also overseeing doctors in more than just Toronto and Vancouver, right? As we continue to grow. So I think the more locations, the more docs that we're managing, obviously the more of my time that will probably take up.
Yeah, I imagine. Well, I bet the hours probably weren't much of a shock to you. I remember doing my OBGYN rotations, and honestly, yes. I feel like there was very few days during my training where it was like the full 26 hours just relentlessly without sleeping. Like, usually even on surgery, you'd get a little nap here and there. But yeah, obs kind, just the babies, they don't stop coming.
Don't stop. I mean, I haven't done OB since I started my fertility fellowship in 2015. So that part of my life is behind me. But I don't think you leave your day job to start a new fertility center in the city that already has a lot of fertility centers to not work hard. Right. So I think that part was not a surprise to me. What was a surprise was maybe it was truly like how much I enjoyed the non-clinical parts of it, of the building, of the company.
And did you always grow up wanting to be an REI specialist, or at what point during the process did you figure out like, oh, this is pretty cool, I could see myself spending a lot of time figuring this out?
Yeah, so I definitely did not grow up always being like, I wasn't like 4 years old saying I'm going to be a doctor. I actually thought maybe I'd want to be an engineer, but then I really did not have an affinity for physics. So that kind of dashed my hopes. And then I ended up obviously going into medicine. But I did always have an affinity for obs-gynae since I was kind of early, I would say, in med school. And yeah, I always had this interest in kind of reproductive health and reproductive physiology. And REI, one of the reasons I love it, I mean, to do OB, you really have to enjoy the chaos. You have to be kind of just game for whatever flies your way. And that's not as much my vibe. I'm like, much prefer to have a little bit of a day list. These are the things I'm going to do today and then I'm done. That's really nice. I also like the short, quick procedures and being able to do a lot of them rather than the really, really big, long, big cases. So just on a technical level, REI appealed to me, but it's also just a lot of counseling and a lot of just sitting down across the desk, across the Zoom and just talking to people. And that's what I like. And then layered onto it, there's all this tech and all this innovation and there's all this like legal and ethical layers. And so I just found it super fascinating. Kind of why it appealed to me so much.
What's the legal aspect to it?
A lot of these, what we would call third-party reproduction, so donor egg, donor sperm, and gestational surrogacy pieces, that involves Health Canada. So that's a whole nother regulatory framework that's federal and not provincial. And, there's questions that come up about embryo ownership in the case of divorce, for example, or, all of these different scenarios. Should we allow intergenerational egg donation? Can your niece be your egg donor? Can your mom be your surrogate? And I don't have the answers, but these are the questions that not infrequently come across our doctor group. And I find that fascinating.
Is there a lot of gray area still, like when it comes to these types of things, or is it all fairly explicitly laid out?
There's a lot of gray area. I think there's the law. And so that's pretty black and white. You have to be 21 to be a surrogate. You have to be 18 to be an egg donor. Can't pay for somebody's eggs or, can't pay someone to give you their eggs. You can't pay for the sperm, etc. But there's still a fair amount of the field of medicine. This field of medicine is new. And so there's still a lot that we're learning and that is not black and white for sure.
I had a close friend go through the process recently, actually twice now, of being a surrogate. And it was kind of interesting just finding out kind of how it works in terms of, you can't pay people to do it. You can't, you can buy them presents, you can buy them gifts, apparently, or at least they've been accepting them. I don't know if that's gray or maybe just outright black.
I leave this to the lawyers. The lawyers tell me to stay in my lane, right? I think the
Don't
law
ask
is receivable expenses. But I mean, but yes, from a gestational carrier surrogacy point of view, we help obviously get them pregnant, follow them till the end of the first trimester, and then they do transition to OB care, right? We take care of people here only until the end of the first trimester. And so a lot of what we do is kind of that initial part of the process. And so I don't always know the details of some of the drama maybe that happens afterwards, maybe that you heard about from your friend.
Hopefully not too much of it. Yeah. What do you guys do more of in general then? Is it IVF? Is it the cryopreservation? Is it, kind of the good old fashioned clinical infertility treatments that don't require the $1 million lab?
I would say, I think we do, I know we do more elective, or let's call it egg freezing due to age-related fertility decline than some of the other centers. And that's because I think our brand resonates with people who don't have infertility. They don't want to over medicalize it. They're not sick. There's something pathologic. And I think coming into a space that is more welcoming, that's less scary, it's less medical feeling, does resonate. And also just that we have the capacity to reach out to them and specifically target that, create an environment for that group of people versus, if there's other clinics and they're full seeing people with infertility, then why would they go to try to, reach out to the, 30 something out there. So we do a lot of egg freezing. We also do a lot of embryo freezing electively, young couples just got married, not ready to have babies yet, but they know they want however many babies. They have good coverage through work. Way more of that than I was expecting. But of course, the majority of our referrals are still for trouble getting pregnant and whatever treatment they may need. And then we do a fair amount of recurrent pregnancy loss assessment and testing and treatment as well. Those are probably our main reasons for seeing people.
Very cool. And quite the diverse set of things to be doing in a day.
Mm-hmm. Yeah. And then we will see people who have if both the egg and the sperm provider, both intended parents, are carriers of a genetic condition, they don't want to pass it on. And some people would like to make embryos and test the embryos for that. And so we'll also see people for that. Yeah.
And it sounds like people, whether it's due to economic factors of just not being able to afford having kids earlier in life, are pushing it further and further back. Like, at what point or what kind of factors go into deciding whether egg freezing or embryo freezing is actually like a recommended option for a couple?
Well, that's such a great question. I think I see our job as gathering as much information as we can, especially knowing the tests aren't perfect, right? And they are snapshots in time, and then kind of laying out people's options. And then kind of depends on their risk tolerance or how they're feeling about the whole situation. So I think important factors like, yes, we would check the sperm. And if there's any issue with the sperm, we can either try to improve it or talk about treatment options. And then we will check people's egg count, right? We'll do an AMH hormone, we'll do an antral follicle count, with the important caveat that those tests don't predict natural fertility rates. They don't predict your chances of getting pregnant if you try in a given month, but they do predict your response to IVF medications or attempts. As I tell patients, these are the words I use with them. I want to try to get you to make more eggs all in one cycle so I can take them out. How easy or hard is that going to be for us to do? And that's related to how much I can help you if you run into trouble getting pregnant on your own. And so if someone's 35, they haven't started yet, maybe they're not going to be ready to start trying for another 2 years, but they want more than one kid. Like, it's not a bad idea to be thinking about this, because the chance you have trouble when you're 38 or 39 or 40 is higher, and my ability to help you the older you get is lower, because the age of the eggs is the single greatest prognostic factor of basically everything we do. Versus if you're 28, you want one kid, you think you'll try the next 4 years, like, you can freeze your eggs if you want, but there's a very low chance you'll use them or you'll need them, right? And so it's just about kind of helping people understand and work through their options in hopefully a way doesn't cause them added stress or doesn't make them feel pressured. I think that's really important.
And so age is the number one deciding factor. What would number two be?
I mean, in terms of fertility preservation for the future, probably ideal family size, I would say. Right? Because if someone's 30 but they want 4 kids and they don't have a partner and they think it'll be a bunch of years before they'll start trying, that's way different than if you want one. And then your ovarian reserve does play a role, because it speaks to how much I might be able to help if we run into trouble in the future.
Gotcha. Interesting.
Yeah. And then unfortunately, for a lot of people, finances, financial situation and employment benefits play a role too.
How common is that now? I've heard this is the greatest new productivity hack at a company is to provide cryopreservation as a employee perk.
It's way more common than when I started in this field. Yeah. Way more common. I think it started with the tech companies, the Metas and the Ubers, Pinterest, Salesforce, of Googles of the world, and then spread to the big banks. And now it's the big accounting firms, the consulting firms, the big law firms. And it's really nice, right? For just people to have that option. We can debate what it does to society and what it values and all of that, maybe another time. But unfortunately, this is it's expensive. And so it's really nice when that doesn't have to be the thing that's driving the decisions, but people can just make the decision that's right for them.
Takes a lot of pressure off.
It can, yeah. I think what's important is that it's not a guarantee. It's medicine, right? Should rarely say never or always, right? And so I think that's why the counseling is so important, that there can, you can freeze a number of eggs or a number of embryos that gives you a very good chance of a future live birth, but it is never a guarantee. And so you want to make sure people aren't relying on that entirely to then delay their family building more than they otherwise would have, right? And so it's that kind of delicate balance of giving people that optionality. But then I always tell people that I'm a little bit biased, and my job is to try to nudge them to not wait too long to try.
And then I'm like vaguely familiar with how the process itself actually works. Like, could you elaborate on just how you actually go about getting the live tissue and getting it into storage, and how you keep it safe and stable and resurrecting it again from the depths of the fridge? Yeah.
Yeah. So we do our egg retrieval procedures here at our Midtown clinic. They're done under like minimal sedation. And it's all done under ultrasound guidance, like vaginal ultrasound. And the whole procedure only takes about 10 or 15 minutes. And basically, we visualize the ovaries on ultrasound, and they're full of big follicles, and those look like big black circles on the ultrasound machine. And we basically just put a very small needle into those follicles vaginally, and it's attached to a vacuum, like a suction. And so the fluid drains and goes into little test tubes. And then immediately on the other side of our procedure room is the IVF laboratory. And so those test tubes get passed off to the laboratory in real time. And they, in real time, examine the fluid under the microscope to look for eggs. And so hopefully each follicle, each big black circle on ultrasound has a mature egg inside. If the plan is to freeze eggs, then that afternoon, a few hours later, the eggs are frozen. If the plan is to try to make embryos, then that afternoon, a few hours later, the eggs and sperm are combined. Embryos are cultured in one of our incubators for 5 to 7 days. And then either 5 days later, we put an embryo back in the uterus, or more commonly, we would actually freeze those embryos for an embryo transfer at a future date. Everything's frozen in these tanks called dewars that really look like kegs on wheels. Like, that is a good image if you just want to have that in your mind. And it's liquid nitrogen. It's like -70. And like I said, it's all alarmed and backuped and, made sure that everything at all times is well sealed and well taken care of, and everyone's reproductive material is kept safe until they need it again. And the other thing is all of the gametes and embryos in the lab are tracked with an RFID tracking system. And so the patients, when they come in, get an RFID card, and then that's kind of tagged to like all of the test tubes and dishes and everything in the lab, so that we can totally track chain of custody through the entire process.
Very cool. And is this like a general anesthetic intubation thing where
it's
you just spray some
it's
lidocaine, and how does this
neither of
go?
those things. It's midazolam and fentanyl through the IV, and that's it. Yeah. So
that is cool. That is cool. And why would somebody choose to go for embryos versus eggs alone?
Also a great question. I think what I tell people is I usually look the person with eggs straight in the eyes, even if they have a male partner who's on the call, and I say, if you're 1,000,000% sure who you want to have babies with, does sort of make sense to freeze embryos for reasons I'm about to explain. But if you're not 1,000,000% sure, then best to freeze eggs and retain your reproductive autonomy. So benefit of eggs, choice in the future. They're yours. They're yours alone. You do whatever you want with them. You don't have to be in a Sofia Vergara situation where, her and her ex-husband had years and years and years of legal battles over their embryos. The benefit of embryos is that there is unfortunately a lot of attrition through the IVF process. And that's why we don't do IVF with no fertility drugs, where we just start with one egg that we take out. We give people strong fertility drugs so they can make 15 or 20 mature eggs at a time that we can take out, because sometimes only 80% of the eggs are mature, and then only 80% of those fertilize, and then only half of those turn into embryos, and then half of those embryos are chromosomally abnormal. And we started with 20, and all of a sudden we end up with, 3 chromosomally normal embryos to transfer. So the benefit of freezing embryos is if you pause the process further along, it's easier to know what you have, and for me to counsel you about what are the chances that leads to a baby in the future. And therefore, should you freeze more embryos, or is that like a really good number? Because if you freeze 18 eggs, it's kind of upstream. So I'm just kind of guessing like, I don't know how many embryos that will be. I don't know what chance of future live birth, especially because remember, like, sperm's really important too. So I can't comment on that. And so it's the people who are like, they're engaged or they're married or they're kind of very sure that they want to have kids together. Sometimes it's just easier to counsel them if we pause the process later on.
Could a person do both? Like, you just in case have the eggs individually as a backup? Does that cost a lot more? Or is it technically a lot more challenging to have
it's
both?
not. There's some very kind of specific reasons why that's not our preference, but a lot of people do end up needing more than one cycle to reach their goals. So some people will do one cycle of eggs, one cycle of embryos.
Gotcha. And then how has the genetic testing, I guess, evolved over the years that you've been doing this? Because there's just been so many advances with gene technology.
Yeah, so very interesting. So we actually have 2 genetic counselors who are on staff. And I think now most fertility clinics have in-house genetic counselors. I don't know how people do REI without genetic counselors these days. They're so integral to my life. And we offer genetic testing at different phases of the patient journey. And I think having really robust reproductive genetic offerings is also one of the things that helps us stand out a bit from some of the others. Like, our philosophy is really like, how much comprehensive care can we provide under one roof, right? And so I'll get back to your genetics question in a second, but like, we have a reproductive urologist who comes, we have a general OBGYN who does our preconception counseling consults, and we have an in-house social worker. So it's really about like, what can we provide here to make it as good of an experience for patients. We offer routine genetic carrier screening to everyone who walks in the front door, should they want to do a panel of 500 genes to see what they're carriers for. And then anyone who's doing IVF has the option to do what's called pre-implantation genetic testing. So that's testing of the embryos that are made in the lab before the embryos transferred into somebody's uterus. And that's because even at age 35, half the embryos that are made are chromosomally abnormal. And that's just how humans are. And so there's that. And then, of course, once people conceive, there's prenatal screening. I'm sure you're more familiar with as a family doctor, but even that's increasing in complexity in terms of NIPT offerings and microdeletion add-ons and 22q and all of these different offerings. And so our genetic counselors really play a key role in all 3 of those, like kind of before, during, and after phases of the patient journey.
Very cool. And is there any difference between the ethics and the legalities of it? Like, if somebody is, I want to definitely have one boy and one girl. Like, is there any? Canada.
Yeah. So one of the things that's in the law is that sex selection is illegal in Canada. So you cannot, when we do genetic testing of the embryos, our reports don't include any information about sex chromosomes unless there's the wrong number of sex chromosomes, right? Where it would be reported as aneuploid. So I truly, and nobody at the clinic knows which embryos are XX or XY. And when patients ask, I just kindly remind them I don't want to break the law or go to jail for them. They're usually okay with that. And then if people, because it's a federal criminal lawsuit, like it's not like a regulation, And then in extreme situations, people can go to the States if they want. What we call family balancing is the euphemism for like, I've had 2 girls, I want a boy. But for that, you have to go outside the country.
Why has Canada drawn that line in the sand so firmly versus right there?
I'll have to ask someone who was involved in that. I suspect it is not unrelated. Well, actually, I don't know. But I think, sex-selective abortion is obviously an issue in some parts of the world and not wanting to tread into that area of ethics. But we can do sex selection for medical indications. So like hemophilia A, like for example, like hemophilia or something that's clearly a sex-selective medical issue, you can do it for those reasons only.
What would be the next most common genetics ethical dilemma that you come across with patient requests?
Oh, it's interesting. I think one of the things that's coming up more and more as we test more and more embryos is the request to put back in abnormal embryos. And I'm just going to leave that out there because I obviously don't have the answer. But, what if you do genetic testing and then people want to transfer an embryo that has trisomy 21?
And what does the law currently state?
There's no law, right? So that's like individual clinic policy. And those are some of the, there are bioethicists in this field and that's their full-time job, and they advise clinics and they advise hospitals, and these are the sorts of questions that come up. I think, what qualifies as a sex-selective medical issue, is also one of those. But again, another episode, you could talk to a bioethicist. That would probably be fascinating.
I'll have to get one's card after we're done here today.
Yeah.
That is very interesting stuff, though. Okay, cool. And then what about on the IVF side? How does that process typically go?
Yeah, it's the same as embryo freezing. Like it's the same as what I basically walked through. Like it's drugs, fertility medication to try to make there be lots of eggs at a time. Eggs come out, mix them with sperm, make embryos. Whether you test those embryos or not is obviously a personal choice. And then instead of those embryos being frozen and on ice for the future, you would then put one back in either immediately or the next month, or whenever people are ready. And so in many ways, egg or embryo cryopreservation or IVF, the process is extremely similar. There's nuances, but for the most part, it's basically a very similar journey.
Do you wind up having like a significant drop off or like attrition rate as you go through the freezing step versus if you just went straight to the IVF and then put it back in vivo?
Can you say that again? Sorry.
Like when you take the egg out and the sperm out, and then if you do IVF, combine the two and then just go straight back into the uterus versus going through the process of the cryopreservation. Like, do you actually lose viability by going through the freezing or not really? Not
really, actually. So, I mean, embryo freezing technology has been around a lot longer than egg freezing technology. And as not an embryologist, I will do my best to explain this. But an egg is a very big cell, right? It's the only cell you can see with the naked eye when it has its cumulus cells around it. And it's mostly water. And so technically to freeze it without it causing crystals on the inside that then break up the mitotic spindle is hard. And so that's why embryo freezing was like mastered as a technological skill basically decades before egg freezing was. But now we've gotten very good at egg freezing too. And so what I would quote patients here, and I can't speak to other clinics, is at least a 90% survival for eggs that are frozen and thawed. But for embryos, it's about 99% freeze thaw survival. And there are some circumstances where putting an embryo in to the uterus that has not just been exposed to extremely high levels of hormones might actually be better. And so most clinics in North America do predominantly frozen embryo transfers now. Of course, not exclusively, it's medicine. There's always exceptions to the rule. But to answer your question, it's usually not such a big downside or detriment. And with sperm, if you freeze thaw it, you lose about half the sample. But if you start with 200 million sperm and then you have 100 million sperm, you still have lots of sperm to deal with. So in most cases, except with very severe kind of sperm factor, it's not an issue.
Very cool. And dare I ask, what is like the low end and the high end in terms of cost, or how do you actually even price it out? Is it like over time, or is it just a lump sum for having the procedures done?
Yeah, every clinic is different. I think our philosophy from the outset, and we talked about this for hours and hours and hours because we wanted to get it right, and we didn't want it necessarily just default to how others were doing it. If that's how we ended up, great, but we kind of needed to go through the motions to arrive at how we wanted to do this. So first we said, okay, what are our pricing principles? Like, what are our values here? And we were like, simple and transparent. Those are our values. Like, how can we make this as simple as possible? And how can we be very clear and upfront about it? And so we made a decision early on to publish most of our costs on our website. And one of the things that one of my co-founders always said was a rising tide lifts all boats, right? And it sounds cheesy, but since we've done that, more and more clinics have also done that. And I don't for a moment say that that's causative, right? But it's nice to see, right? Like it's nice to think maybe that had some market pressure and improve the transparency for all people at different clinics. For us, there's basically, I mean, egg freezing actually right now, it's not a secret, it's $8,000 plus the drugs. That's what it costs. And for IVF, it's $13,000 to make the embryos, plus the drugs, plus the genetic testing, if you want to do it.
Because it's not bad in terms of
The numbers.
peace of mind. Yeah.
So, and embryo freezing, yeah, so that's what it costs. And then, there are obviously other things that are covered in Ontario by OHIP, and then other things that are private. When Vancouver, pricing is set, that information will be available. But obviously these prices are also dynamic and will evolve over time. As
Like when you get the
any service, right?
fancy steak at the restaurant, market price.
Yeah, no, we're not doing that. That's not transparent, right? But it's really interesting, or at least I think it's really interesting. One of the issues, obviously, with this field of medicine is it's not accessible to everyone because of the cost. And I'm so excited that the Ontario government just made an announcement a few days ago to increase the budget for the Ontario Fertility Program and bring in a tax credit in 2025 to make fertility care more affordable to Ontarians. And it sounds like BC might be also getting some IVF funding in the spring. And so I think the momentum is really great. But one of the tensions that I'm watching is, will all of the additional technology that's coming drive down the price or drive up the price? Because it kind of could go either way. And that's a complicated kind of space to keep an eye on.
Interesting. And then, is anybody freezing sperm? Like, how common is that?
Very common. Yeah, that's been around, it's probably been doing that for 5-6 decades. Yeah, I don't think it's technically nearly as challenging as eggs or embryos. And also when you're dealing with hundreds of millions of sperm, like I said, if you lose half on average in the freeze thaw, that's just kind of how it is. Some people will freeze sperm truly electively. Men are always making new sperm. People with sperm are always making new sperm, unlike people with eggs who are born with all their eggs and they never make more. So there's more of a biological imperative to freeze. But of course, before cancer treatment or before, before vasectomies, there could be lots of reasons you may want to have a backup.
Is there much of an age trigger like there is at the 35 cutoff for women, or not so much?
There is a decline in sperm quality with age, but it is not as marked as with eggs. The other thing is there's also an increase in some de novo autosomal dominant conditions with really advanced paternal age. So we generally think with sperm age over 45 or 50, there's an increased risk of autism and schizophrenia and also some autosomal dominant conditions. And I don't think we talk about that very often.
No, it's usually just the female-sided factors.
Just the egg. Yeah, just the eggs. So, yeah, so we offer that for sure. And we definitely see. The other reason we do sperm freezing, I should just call it, is for people who are about to start gender affirming therapy.
Gotcha. And then, I'm not familiar with the case, but who did get Sofia Vergara's embryos? How did they split that one up?
I think what happened, I have to look at the latest because it was in the courts forever. They had 2 embryos and she did not want to use them. And he wanted to use them with a surrogate or with his new wife to have babies. It was very messy. I will say the wrong thing if I try to say more than that.
Okay, we won't try to paint you into a corner on that one.
Thank you. My
Well,
pop
this has
culture
been-
knowledge is like mediocre, I would say, you know?
Well, this has been very enlightening, though, nonetheless. I do appreciate you taking the time to chat this afternoon. I've learned quite a bit, and I don't know, unless you have anything else to shout out. I mean, if anybody's interested in the fertility treatments or in having some eggs frozen or going through the IVF process, what's your guys' website? Where can they find you?
Yeah, they can find us at twigfertility.com. You can also follow us on Instagram at twigfertility. We're very active there, and those are the best places to stay up to date on all the happenings.
Do they need a referral or can they just show up?
Neither, but you can self-refer through the website. So if you go to our website and click book now, then we can help you.
Right on. Dr. Rhonda Zwingerman, thank you so much for joining me today. I appreciate it.
Thank you for having me.
Thank you for joining us this week on Leaders in Healthcare. If you enjoyed this episode, please like, subscribe, or leave a comment. And if you found this episode helpful, don't forget to share it with your network.